First one is the general properties of Enterobacteriaceae family characters. The members of Enterobacteriaceae family include few following properties. They are gram-negative aeros, facultative anaerobic bacilli, non-fastidious. It can grow in ordinary media like nutrient agar, and it will ferment glucose, and it will reduce nitrate to nitrite, and it is oxidase test is negative and catalase test is positive, except Shigella dysentery type 1, and except Shigella and Klebsiella they are generally motile. Natural habitat mostly the Enterobacteriaceae. The commensals are mainly seen in human intestine, which is called as coliform bacilli. Next one is a classification of family Endobacteriaceae based on lactose fermentation. Lactose fermenters all are coliform bacilli. It will ferment lactose producing acid. Colonies of McConkie agar. It will produce pink color colonies. The examples are E. coli, Klebsiella, and Citrobacter. Next one is a non-lactose fermenter. It do not ferment lactose and it will produce pale or colorless colonies. The examples are Salmonella, Shigella, Proteus, Morganella, Providentia, and Yersinia. Next one is a late lactose fermenters. Previously, it is known as paracolon bacilli. It will ferment lactose after 2 to 8 days of incubation. Colonies of McConkie agar at 24 hours of incubation, it will produce pale or colorless colonies. After 2 days, it will produce pink color colonies. The examples are Shigella sonnei. First one is the E. coli. It is one of the most important human pathogen. Mainly, it is seen in the intestine of human and animals. After excreted in fecus, it will remain viable for some days in environment. The detection of fecal E. coli, it is thermotolerant. In E. coli, it will survive at 44 degrees Celsius, and it is taken as an indicator of recent contamination of drinking water with human or animal fecus. Next one is the clinical manifestation of E. coli. Mainly, it will cause urinary tract infection, which is caused by uropathogenic E. coli organism, and it will cause diarrhea. It is caused by 6 types of Diaryogenic E. coli, and other symptoms of E. coli are it will cause abdominal infection. E. coli is the most common cause of primary bacterial peritonitis. It will occur spontaneously, and secondary bacterial peritonitis, it will occur secondary to intestinal perforation, and it will cause visceral abscess such as hepatic abscess. Next one is the pneumonia, especially in hospitalized patients. Ventilator associated pneumonia, it will occur. Next one is the meningitis, mainly in neonate it is seen. Wound and soft tissue infection is caused by E. coli. Osteomyelitis and endovascular infection and bacteremia is seen. Next one is the urinary tract infection. E. coli, uropathogenic E. coli. It is the single most common pathogen, accounting for 85 to 95% of urinary tract infection. Uropathogenic E. coli serotypes O1, O2, O4, O6, O7, and O75. It is responsible for urinary tract infection. Route of spread, ascending spread. After colonizing the periurethral area, this E. coli will ascend into the urinary tract. From urinary tract, it will reach the bladder. From bladder, later it will reach to the kidney. Through this way, ascending route is spread. Next one is the descending route. In descending route, hematogenous seeding of E. coli into kidney, which will result in inflammation of kidney. Next one is the types of urinary tract infection. Depending upon the site involved, there are 2 types of urinary tract infection. One is lower urinary tract infection, and the other one is the upper urinary tract infection. In lower urinary tract infection, in which cystitis and urethritis is seen, In upper urinary tract infection, only kidney affection is seen. In lower urinary tract infection, the symptoms are dysuria, urgency and frequency. In upper urinary tract infection, fever, vomiting and abdominal pain is seen. Route of spread of lower urinary tract is ascending route, and in upper urinary tract infection, both ascending and descending route is common. Lower urinary tract infection is more common and upper urinary tract infection is less common. Virulence factor of lower urinary tract infection is fimbriae, and the upper urinary tract infection virulence factor is capsula K antigen. Next one is the predisposing factors that promote urinary tract infection. Mainly the urinary tract infection is occurring more commonly in females due to short urethra and close proximity to anus, and in pregnancy also it is more common due to physiological obstruction in urinary tract due to growing fetus, and this will lead to prolonged stasis of urine and asymptomatic bacteriuria is seen. Others such as presence of urinary catheters and urinary stones or prostate enlargement will cause urinary tract infection. Next one is the laboratory diagnosis of Uropathogenic E. coli. Specimen collected, clean, voided, midstream urine is taken. It is one of the most common specimen for urinary tract infection diagnosis. Next one is the suprapubic aspiration is the most ideal specimen. For coma or infants, it is used. In catheterized patients, the urine should be collected from the catheter tube, not from the bag. Next one is the transport. Urine should be stored in refrigerator or stored by adding boric acid. Under direct examination, screening tests are done as follows. One is the wet mount examination. It is done to demonstrate pus cells in urine. Pyuria greater than 8 pus cells per cubic mm or 4 lakh pus cells excreted in urine per hour is taken as significant for urinary tract infection. Other tests such as leukocyte esterase test, nitrate reduction test, which is otherwise known as Crace test, and catalase test is done to demonstrate the urinary tract infection. Next one is a gram staining of urine is not a reliable indicator because low bacterial count in urine and pus cells will rapidly deteriorate and may not be seen well. It may be limited to pyelonephritis and invasive urinary tract infection cases, and count of greater than 1 bacteria per oil immersion field is taken as significant. Next one is the culture for urinary tract infection. Urine is inoculated into McConkey agar and blood agar combination or cysteine lactose electrolyte deficient agar. Next one is the cause concept of significant bacteriuria. A count of greater than 105 colony forming unit per ml of urine is considered as significant, which indicates the infection, which is referred as significant bacteriuria. This method was developed by cause low count of less than 104 colony forming unit per ml, which is due to the commensal bacteria. It is due to contamination during voiding and it has no significance. Low counts may be significant in following conditions such as patients on antibiotic treatment or diuretic drugs. It is significant. Infection with some gram-positive bacteria like Staphylococcus aureus and Candida, pyelonephritis and acute urethral syndrome, and sample is taken by suprapubic aspiration. This is mainly seen in infants and coma patients. Next one is the quantitative culture. It is done to count the number of colonies. This quantitative culture is done by semi-quantitative methods such as standardized loop technique and quantitative methods such as pour plate method. Antibody-coated bacteria test is used to differentiate upper and lower urinary tract infection. Next one is the Diaryogenic E. coli. In that first one is the Enteropathogenic E. coli. Enteropathogenic E. coli. Frequently, it will cause diarrhea in infants. Rarely, it is a sporadic diarrhea in adults. It is non-toxigenic and non-invasive. The mechanism of diarrhea is first it will cause adhesion to intestinal mucosa. Then it is mediated by plasmid coated bundle forming villi, attaching and effacing lesions on the intestinal epithelium is seen. Next one is the Endotoxygenic E. coli. It is one of the most commonest cause of traveler's diarrhea, which will cause in 25 to 75% of cases, in which the in endotoxygenic E. coli, it will cause acute watery diarrhea. Mainly it is seen in infants and adults. The common serotypes of endotoxygenic E. coli are O6, O8, O15, O25, O27, O153, O159, etc. Enterotoxygenic E. coli is toxigenic but not invasive. Next one is the pathogenesis. Attachment to intestinal mucosa. It is mediated by colonization factor antigen. Diagnosis done by detection of toxin by in vitro and in vivo method. Next one is the enteroinvasive E. coli. The common serotypes associated in enteroinvasive E. coli are O28, O112, O114, O124, O136, O152, etc. The pathogenesis of enteroinvasive E. coli, it is not toxigenic but it is invasive. The epithelial cell invasion is mediated by plasmid-coded antigen, which is called as virulence marker antigen. In enteroinvasive E. coli, it is biochemically, genetically, pathogenetically, it is closely related to Shigella. Manifestations of enteroinvasive E. coli are mainly the ulceration of bowel and dysentery is seen. Mainly it will resemble like shigellosis. The diagnosis of enteroinvasive E. coli is detection of virulence marker antigen by ELISA and serenators inoculation into guinea pig eyes, which will produce conjunctivitis in guinea pigs. Enteroinvasive E. coli are biochemically atypical. It is non-motile and it is lactose non-fermenters. Next one is the enterohemorrhagic E. coli. The serotypes associated with enterohemorrhagic E. coli are O157. H7 is the most common serotype. Some rare serotypes are O26, H11, O6, O55, O91, O103, O111, and O113. Enterohemorrhagic E. coli, it is usually transmitted by contaminated food, mainly lettuce, spinach, sprouts, and undercooked ground beef. It is prevalent in industrial countries. Other diaryogenic E. coli are commonly seen in developing countries, but it is seen in industrialist countries. Low infective dose of less than 102 colony forming unit of enterohemorrhagic E. coli can cause intake the infection. The pathogenesis of enterohemorrhagic E. coli, it will secrete a toxin called verocytotoxin or Shiga-like toxin. Diagnosis sorbitol McConkie agar enterohemorrhagic E. coli. In contrast to other E. coli, it will not ferment sorbitol. Toxin detection, cytotoxicity in vero cell lines, which is a gold standard method. Next one is the fecal toxin antigen detection by ELISA rapid test. PCR can be used to detect gene coding for virulent verocytotoxin. Next one is the Enteroaggregative E. coli. It is named because it will access HEP2 cells in a stacked brick fraction. Most strains are O untypeable but H typeable. Pathogenesis colonization. It is mediated by aggregative adhesion fimbria 1 and it is regulated by AGGR gene. Produce EAST1 toxin. Enteroaggregative heat stable enterotoxin 1. Next one is the manifestation of verocytotoxin. It has predilection for endothelial cells and it will cause capillary microangiopathy, which will lead to hemorrhagic colitis. In hemorrhagic colitis, bloody diarrhea is seen, abdominal pain and fecal leukocytosis, but in hemorrhagic colitis no fever is seen. Next one is the hemorrhagic uremic syndrome. Injury to small vessels of kidney and brain can lead to bloody diarrhea and thrombocytopenia, renal failure, and encephalopathy, but without fever. It is more commonly seen in children. Next one is the manifestation. Persistent and acute diarrhea are common in developing countries. E. coli O104H4 is an enteroaggregative strain that has caused major outbreaks in Germany in 2011. Peculiarity is it will produce Shiga toxin and it will cause hemolytic uremic syndrome. Next one is the diffusely adherent E. coli. It will adhere to HEP2 cells in a diffuse pattern and it will express diffuse adherence fimbriae which contribute to the pathogenesis. Next one is the Klebsiella. Klebsiella is a non-motile organism which is lactose fermenter. It is capsulated and it will produce mucoid colonies. Klebsiella pneumonia is urase positive. In Klebsiella pneumonia, it will mainly cause pneumonia, urinary tract infection, abdominal wound and surgical site infection. Next one is the Klebsiella oceana species. It will causes oceana, which means foul-smelling nasal discharge or atrophic rhinitis. Next one is a Klebsiella rhinoscleromatosis. It will cause rhinoscleroma. Next one is a Proteus. Proteus is motile. It is non-lactose fermenter. Type character or phenylalanine deaminase test is positive in Proteus. Both Proteus mirabilis and Proteus vulgaris are hydrogen sulfide and urase positive. Indole test is positive for Proteus vulgaris and negative for Proteus mirabilis. Pleomorphism, gram-negative, appear in various forms, Coca bacilli, and in filamentous form. Or in Proteus, it will produce order characters putrid, fishy, or seminal order in cultures. Swarming. Proteus has the ability to swarm or spread on solid media. Others, certain organism also has an ability to swarm, such as Proteus, Clostridium tetani, Vibrio parahemolyticus, and Serratia. Next one is the die-ins phenomenon. It is done to know the relateness between different strain. Proteus it will form struvite stone in bladder in alkaline urine. Next one is the Shigella. Shigella species are the main agent for the bacillary dysentery. Four species are mainly recognized. One is the Shigella dysentery, Shigella flexneri, Shigella boydii, Shigella sonei. The most harder is the Shigella sonei. The most common species in the world are Shigella sonei. In India, the most common species is the Shigella flexneri. Next one is the pathogenicity. So the Shigella is mainly transmitted through ingestion through contaminated fingers, which is the most common, food and water or flies, and rarely by homosexual. Infectious doses. Shigella has a low infectious dose, 10 to 100 bacilli. Others with low infective dose include enteropathogenic hemorrhagic E. coli, Entamoeba histolytica, and Giardia. Salmonella typhi has 10 is to 3 and 10 is to 6 bacilli power, and Vibrio cholerae has 10 power 6 to 10 is to 8 bacilli, in which the bacilli will enter through the mucosa through M cells. Invasion, it is mediated by large virulence plasmid, direct cell to cell spread. It occurs by inducing actin polymerization of host cell. Next one is the exotoxin. First one is the Shigella enterotoxin, which has two types, Shigella enterotoxin 1 and 2, which is found essentially in Shigella flexneri. Shiga toxin, it is a cytotoxin, which is produced by Shigella dysentery type 1. endotoxin, it will induce the intestinal inflammation and ulceration. Next one is the complication of Shigella. It will mainly cause the intestinal complications such as toxic megacolon and perforations and rectal prolapse will be there, and metabolic complications such as low blood sugar, hyponatremia and dehydration, and sodium level will be lower. Ecri syndrome or toxic encephalopathy. It is also a metabolic complication of shigellosis. Next one is a post-infectious phase. Patients expressing HLA-B27 will develop autoimmune reaction in which the patients will suffer from reactive arthritis, ocular inflammation, and urethritis month after Shigella flexneri infection, which is mainly seen in 3% of cases, hemorrhagic uremic syndrome, and hemorrhagic colitis, which is produced by Shigella dysentery type 1, which is due to producing Shiga toxin. This Shiga toxin, also called as Shiga bacillus, rarely it will cause bacteremia, meningitis, pneumonia, vaginitis, and keratoconjunctivitis. Next one is a laboratory diagnosis of Shigella. In specimen, mucus flakes of stool is seen. The culture media, common media for both Shigella and Salmonella. Transport media scarce buffered glycerol saline, selective media deoxylate citrate agar, psilocybin deoxylate cholate agar, and Salmonella shigella agar is used. Next one is the enrichment broth, gram negative broth, cell 9F broth, tetrathionate broth is used for laboratory diagnosis of Shigella. Important biochemical properties. It is non-motile, non-lactose fermented except Shigella sone, which is a late lactose fermenter. Catalase positive except Shigella dysentery type 1. Mannitol fermenting except Shigella dysentery. Next one is the typing of Shigella. Serotyping Shigella dysentery 15. Shigella flexneri 6. Shigella boydii 19. Serotype Shigella sone 1. Next one is the colocin typing, which is otherwise known as bacteriocin typing, which is done for Shigella sone, which it has 26 colocin types. Next one is the Serratia. Serratia marcescens, it will produce characteristic red non-diffusible pigment, which is known as prodecuson. It is a saprophyte which is found in water, soil, and food. Mainly, it will grow in sputum after collection, and it will make the sputum red due to pigment production. This condition is known as pseudohematitis. It is mainly reported in nosocomial infection. Mainly, it is seen in hospital acquired infection. The hospital strains are often non-pigmented and multi-drug resistant, and it will produce ampicillin beta lactamases. Next one is the Yersinia pestis. It is a most common important agent of plague. It is a zoonosis, which means infection occurred from the animals. It is transmitted from rodent by rat flea. Next one is the epidemiology of plague. Plague is one of the greatest killer known to mankind. In Africa, it accounts for maximum cases. In Africa, 97% of cases noted. First one is the plague pandemic. There were 3 pandemics reported, each of which the different biotype of Yersinia pestis. First pandemic is noted in AD 541, which is associated with biotype mediavilis, and the second pandemic is noted in 14th century, which is known as the Black Death, which is a severe type with biotype Antiqua, and the third pandemic is noted in 1884. It is mainly affected in India and China with biotype Orientalis. Next one, in 1994, in Surat, epidemic is noted. In 2002, Shimla outbreak is seen, and in 2004, bubonic plague in Uttaranchal is seen, and 4 potential endemic foci are there in India at present, which include region near Kolar, it is seen, and Beat Latter Belt in Maharashtra, Rogru in Himachal Pradesh, and Dankat village, Uttaranchal, it is seen. Reservoir of plague is wild rodents such as gerbils, Tatra indica, field mice, and forest bandicoot. The source of infection are mainly from the infected wild rodents, rat fleas, and cases of pneumonic plague. The main important vector is for the plague is rat flea. Another one is the Synapsula chiapsis. It is the most efficient vector which is found in North India. Synapsula asiatica, which is less efficient, which is found in South India. Human flea, which is known as Pulex irritans, which is very rare and it serves as vector. Next one is a plague cycle. Plague usually exists in two natural cycle. One is domestic cycle and the other one is the wild sylvatic cycle. Domestic cycle which occur in humans, rat, fleas and rodents. Wild sylvatic cycle it occur in nature between wild rodents which is independent of human. Mode of transmission. Human plague is frequently contracted from mainly in human. The infection occurred from the infected rat flea, which is the most common. And other one is the direct contact with tissues of infected animal. Droplet inhalation, which is from man to man, from cases of pneumonic plague. Bite of an infected human flea, which is one of the most common type. Block flea, the bacilli will multiply and it will block the proventriculus of flea. Then this flea will regurgitate the blood mixed with the bacteria into the bite, and from this way the infection is transmitted. So the partially blocked flea is more dangerous than completely blocked flea because the survival rate is longer inside the burrow, and the survival rate is may last for 4 years in certain species. Extrinsic incubation is the interval between flea acquiring infection through blood meal and it will become a blocked flea, which is usually only about 2 weeks. Next one is the Chiopsis index. Greater than 1% indicates plague outbreak is likely to occur. Seasonality. Plague is usually seen mainly in North India and mainly during month of September to May it is seen. Throughout the year, mainly it is seen in South India. Next one is the clinical types of human plague. First one is the bubonic plague. It is one of the most common type. It is transmitted by bite of infected rat. The incubation period of bubonic plague is 2 to 7 days. Mainly the bubonic plague it will cause buboes, which means enlarged regional lymph nodes. The most common site of bubonic plague is the inguinal lymph node. It cannot spread from person to person as the bacilli are locked up in buboes. Next one is the pneumonic plague. It occurs mainly from inhalation of bacilli through droplet inhalation. The incubation is short in pneumonic plague. The incubation period of pneumonic plague is 1 to 3 days. The clinical feature of pneumonic plague is respiratory symptoms such as cough, hemolysis, dyspnea, and chest pain will be there. Pneumonic plague is very rare. It will occur less than 1% of cases, but it is highly infectious and it is highly dangerous. Agent of bioterrorism, aerosolized Yersinia pestis is possible source of bioterrorism attack. Next one is the septicemic plague. It will occur secondary to spread of bubonic or pneumonic plague. After bubonic or pneumonic plague, it will occur. The incubation period of septicemic plague is 2 to 7 days, in which the involvement of blood vessel is seen and hemorrhages in the skin and mucosa. So it is named as Black Death. Next one is the laboratory diagnosis. The specimen should be collected. First should be aspirated from bubo in bubonic plague, and sputum should be collected from for the pneumonic plague, and blood should be collected. And under direct microscopy, gram staining, it will reveal pus cells and gram-negative oval coca bacilli with rounded ends surrounded by capsule. Next one is the Weissen stain or methylene blue staining. It will demonstrate the bipolar appearance. Next one is the culture for Yersinia pestis. It will mainly grow at 27 degrees Celsius, but the capsule will develop at 37 degrees Celsius. Blood agar colonies are non-hemolytic and which is dark brown pigmented. Under McConkie agar, non-lactose fermented colonies are produced. Stalactite growth seen or nutrient both with oil or ghee floated on the top is seen in Yersinia pestis culture. Next one is the vaccine for Yersinia. WHO recommends using vaccine only for prevention of outbreak, not for general use. Mostly formalin killed vaccine. So says modification of original Halfkine vaccine. It is prepared in Halfkine Institute, which is situated in Mumbai. This vaccine is given subcutaneously, 2 doses, 4 weeks apart, and a booster after 6 months is given. Protection is only short and it is less than 6 months. It is not protective against pneumonic plague and it has a side effects and less than 6 months of age. And live attenuated vaccine based on strain EV76, which is used in Soviet Union, which also has side effects. Next one is the Yersiniosis. Yersiniosis means Yersinia infection other than Yersinia pestis. That means Yersinia pseudotuberculosis and Yersinia enterocolitica. Clinical manifestation. Yersinia enterocolitica is more frequently reported clinically than Yersinia pseudotuberculosis. It is a self-limited gastroenteritis in which the diarrhea with or without blood is seen. Mostly it will occur in young children in which the intestinal complication is seen. Mostly it will occur in older children, characteristic by terminal ileitis is seen, inflammation of terminal ileum. Mostly it is caused by Yersinia enterocolitica and mesenteric adenitis is seen. Mostly it is caused by Yersinia pseudotuberculosis and pseudoappendicitis is caused by both species in which appendectomy is not indicated. Post-infective phenomena is most commonly seen in adults. It is mainly occurs by Yersinia enterocolitica as a result of autoimmune activity. Next one is the manifestations include reactive arthritis seen in people with HLA-B27 antigen, erythema nodosum, and Graves' disease, which is independently of HLA-B27 antigen. Next one is a super antigen. Some strains of Yersinia pseudotuberculosis, it will express a super antigen mitogen which will cause scarlet-like fever in Russia and Japan is called as me fever. It is linked to the pathogenesis of Kawasaki's disease. Next one is a laboratory diagnosis of Yersinia enterocolitica and Yersinia pseudotuberculosis. It can be differentiated from Yersinia pestis. Differential motility, it is motile at 22 degrees Celsius, but it is not motile at 37 degrees Celsius. Cold enrichment, growth will improve on refrigeration under 4 degrees Celsius and Yersinia enterocolitica and Yersinia pseudotuberculosis, it is urease positive, but in Yersinia pestis, it is urease negative. Test to differentiate Yersinia enterocolitica from Yersinia pseudotuberculosis is sugar fermentation is done. Ornithine decarboxylase bogus Posca test positive. Only for Yersinia enterocolitica is done. Thank you.